Okay, class, Chapter 10, the ankle and foot joints. Just going to keep going. And what's a sign of royalty to you guys? What do you think? Well, back in the days, during the Chinese Empire, sign of royalty was basically, that's it, small feet. They would basically bind their feet together so that they couldn't walk. They had to be weighted on hand and foot. That's where the phrase comes from. So if they had to go to the bathroom, they had to be carried to the bathroom. If they wanted to eat, they had to be carried to the dining room. They had to be carried to the bedroom. And then eventually it looked like this on the bottom of their, see how the toes curl in? Now you think that's disgusting, right? Why would anybody do this? But guess what? A couple years ago, women were doing not entirely this, but remember when Sex and the City and Jimmy Choo shoes were real popular? Well, people started to remove their third metatarsal because if they had big feet, they wouldn't actually fit into these. So they would have to remove a bone just to fit in these. Now, this in itself is a problem because look at this, you trying to walk on this, that's very difficult. As ladies know, when you go to a wedding, you wear these, you take your pictures, and by the end of the wedding, you're pretty much off of them because they hurt like heck. So, you know, interesting stuff. But the ankle itself, 26 bones, 19 large muscles, there's small intrinsic muscles, and there's more than 100 ligaments. What's the ankle and foot for? Well, support and propulsion. Foot trouble is a common ailment. Poor foot mechanics leads to foot discomfort. No substitute for adequate muscular development, strength, and proper foot mechanics. Mentioned that throughout the whole semester. Strength, 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 but a balance in strength, okay, and proper foot mechanics. So if you remember that nice little video I showed you of all the muscles that are working while you're walking, well, first, normal walking, there's 60% of stance phase, and then there's 40% of your swing phase. So the first thing you do is you heel strike, then loading response, then mid stance, terminal stance, pre-swing toe off, and then initial swing, mid swing, and terminal swing. Okay, so that's basically one step here. All right. Now, the stance phase, heel strike occurs when landing on the heel. The foot should be in supination. Mid-stance immediately follows with the foot moving into pronation. Those are people that have flat feet or too much pronation, then ends up having knee pain or hip pain because then you have no way to make it back into supination and then push off. So you overpronate. Toe off follows mid-stance, foot returns to supination prior to entering the push-off. Okay. Swing phase occurs when the foot leaves the ground and the leg moves forward to another point of contact. So what are problems? Lots of problems that can occur with the foot. The foot is too rigid and does not pronate adequately. Foot remains in pronation past the mid-stance, so you get some torque on the knee. Walking, one foot is always in contact with the ground, but in running, there's a point when neither foot is in contact with the ground and you're up in the air, almost flying. Okay. Now we can move into running. There's a couple of you in here that like to run. So when you look at running, forefoot versus midfoot versus heel strike. So when you run, how do you plant? Okay, does your heel strike first? Do you go midfoot or you go forefoot? Okay, how do you run? What's the best out of those? What's the difference? And if you look at this guy here, barefoot running has become really popular as well. So we'll talk about which one of these, forefoot, midfoot, or heel strike is the best. Okay. Okay, so there's a lot of you that heel strike, meaning your heel strikes first. Okay, 75% of runners run straight, therefore heels hit first. Most injuries occur here due to the strength imbalances though. So if you don't have proper strength, you're going to get a lot of injuries if you heel strike first. Okay? So that's heel strike first. Okay? And 75% of runners, that's what they do. But if this is the way you run, and the way you can tell if this is the way you run, if you look at your running shoes and your heel is worn out right there. What's even more concerning is if one side is worn out more so than the other. But really, if you run like this, it's not that it really requires you to have good strength balance, hamstrings, quads, glutes, all that stuff. Okay. Now, what about forefoot? Forefoot is you run on the balls of your feet. Now, Brandon, heels do not touch. Sprinters, triathletes, relies heavily on leg strength. That's why a lot of runners, they work on their legs. But if they they don't have the leg strength, guess what they'll try to do? They'll try to compensate. They may lean forward a little bit to compensate. Okay, and your barefoot runners are your forefoot runners as well. So these are your. I was thinking, look at it, she's got nice feet here, but running on this terrain. So this is just obviously this is just a model, a pose. She's not going to run all this with all this, but. You see her foot's kind of going in, her toes going in here a little bit. That would be concerning. Okay, and you can see that over the years she's actually worn shoes that are too tight because this foot is going in, and see how the pinky's coming up. Really, if you have proper footwear, your feet should almost splay out. You ever look at Fred Flintstone feet? Those are feet that have never worn shoes before. Those are normal. All right, so what's the best kind of running? Well, the research shows that midfoot running is the best, where the whole foot hits the ground. And guess what? Kids run this way. So we always go back to what kids do. Kids do it naturally, they do it with less effort, and they do it with less injuries. So best, less injuries, injury prevention. So let's say somebody has Achilles tendonitis, somebody has plantar fasciitis, somebody has knee pain, and if they want to return to running, using the midfoot strategy would be a good way, but it's not for speed. So if you're a sprinter, then you don't want to run this way. You'll be slow. You'll come in last. Okay. This is best for less stress on the Achilles, less stress on the plantar fascia and the knee. And so you would strike foot, mid strike. Okay. So just like that. I mean, this is you don't land exactly like this, but this is how you would run, is basically the midfoot. So the forefoot and the heel are one flat. Watch kids run. It's very interesting. Okay. All right, so bones. There's 26 bones that form an arch. The body weight is transferred from the tibia to the talus and the calcaneus or tarsal bones. There are 5 other bones in the rear foot and midfoot known as the tarsals. And the navicular is between the talus and the 3 cuneiforms. The cuboid bone is between the calcaneus and the 4th and 5th metatarsals. There's 5 metatarsals anterior to the tarsals, 5 phalanges, 3 phalanxes in each, except the first toe, which contains 2 phalanx, 2 sesame bones beneath the first metatarsal bone. So sometimes these can get inflamed from a lot of running, and barefoot runners sometimes they may even fracture the sesamoid bone. Ankle injuries, yikes, look at that. That's a severe ankle sprain right there. And soccer, that's very common in soccer. Here's the bones. Again, here's the talus. Okay. Here's the navicular. Here's the medial cuneiform, the intermediate cuneiform, the lateral cuneiform. Here's the cuboid. Here's the calcaneus. This is the bottom. Sometimes you get a heel spur right around here. If your plantar fascia is real tight, you can get heel spurs right here, which is a bony overgrowth. Right. Here's the tibia. Here's the fibula. The distal malleoli of the tibia and the fibula are enlarged and protrude horizontally and inferiorly. So basically that's the malleolus here and here. That's your ankle, those bones that make up your ankle, medial malleolus and lateral malleolus. They're enlarged and protrude horizontally and inferiorly, serve as a pulley for posterior tendons, and this increases the mechanical advantage of muscles in performing inversion and eversion actions. Remember, I mentioned this early on, that your body is a bunch of pulleys and levers, and learning to manage those pulleys and levers is probably the best way to avoid injury. Pulley for the posterior tendons, you have the peroneus brevis and peroneus longus immediately behind the lateral malleolus. The way that you can remember is the mnemonic Tom, Dick, and Harry muscles are immediately posterior to the medial malleolus. So Tom is tibialis posterior, Dick is flexor digitorum longus, and Harry is flexor hallucis longus. Bones, base of the fifth metatarsal, enlarged or prominent, serve as insertion for the peroneus brevis and tertius, and very commonly fractured. You miss a step running, people that haven't ran for a while and they start running again, or those that start barefoot running when they've never ran barefoot, they'll usually fracture their fifth metatarsal. Tibialis anterior inserts on the inner surface of the medial cuneiform and the base of the first metatarsal. Peroneus longus inserts on the undersurface of the medial cuneiform and the first metatarsal. And the posterior tib, you get a lot of posterior tib tendinitis because it has multiple insertions on the lower inner surface of the navicular cuneiform as second through fifth metatarsal bases. So runners will get a lot of posterior tibialis tendinitis. Extensor digitorum longus inserts on top of the second through fifth distal phalanxes. Flexor digitorum longus inserts on the undersurfaces of the second through fifth, and the extensor hallucis longus inserts on top of the first distal phalanx. Flexor hallucis longus inserts on the undersurface of the first distal phalanx, and the posterior surface of the calcaneus, very prominent, serves as a point of insertion for the Achilles tendon of the gastroc. So you remember Kevin Durant tore his Achilles. Kobe Bryant tore his Achilles tendon. Charles Barkley tore his Achilles tendon. So there's a plethora of high-level athletes that have torn their, and he had a Liz Frank fracture. So he did this while he was surfing, and basically his foot, he recalls it as foot kind of going backwards, where the board hit it when he crashed into a wave. And the Liz Frank fracture, this is basically his foot right here. Look at all these fractures. And then there's the ligaments. I mean, he did a lot of damage to it. So not only did he fracture the third and fourth, but he also had injuries to the first and second metatarsal cuneiform joint as well. Okay, so this is actually pretty common in the NFL, but not so common in surfing. All right, the tibiofibular joint. You have a syndesmotic amphiarthrodial joint, joined at the proximal and distal tibiofibular joints. Minimal movement possible. Ligaments and a strong, dense interosseous membrane between the tibia and fibula shafts provide support. The distal joint becomes sprained occasionally in heavy contact sports. So if you sprain your ankle, you've definitely sprained right in here. Syndesmosis is a high ankle sprain. It's a good quiz question. Primarily involves the anterior inferior tibiofibular ligament. Okay, so the most common ankle sprain is the anterior talofibular ligament, ATFL. But a high ankle sprain primarily involves the anterior inferior talofibular ligament. I'm sorry, inferior tibiofibular ligament, which is right in here. More severe injuries can involve the posterior tibiofibular ligament, interosseous ligament, and interosseous membrane here. So if you have injuries along this, then it's going to be a lot more longer and a little bit more crucial for you to get back to work and play. We talked about this in class, Dr. Merkin's RICE protocol in 1978. Advanced research shows that really just use ice for pain relief. Heat exertion, decrease your body temperature, maybe delay the healing if you're doing UFC or boxing. But if you really have no pain, then there's no real reason to ice it. Okay. The phases of healing, just to remember, you have inflammation, which is a cellular and vascular response. That's normal. Then you have repair, replacement of necrotic and damaged tissue, and then remodel, which is reshaping and reorganized tissue. So if you have no pain and you're icing, you're delaying the inflammation process, and then eventually you're delaying repair, and then eventually you're delaying remodel. So here's the key. Inflammation can occur without healing, but healing cannot occur without inflammation. Alright, continuing on, you've got the ankle and talocrural joint, which is a hinge or ligaments type joint. As you know, that I've asked these type of questions on the quiz, so make sure you have these in your notes. 50 degrees of plantar flexion, 15 to 20 degrees of dorsiflexion, so that's something that you want to strive for. If you don't have that 10, 15, 20 degrees of dorsiflexion, your squats are going to be affected, your lunge is going to be affected, your running is going to be affected. The greater range of dorsiflexion with the knee flex reduces gastrocnemius tension. So if you're prone to calf pain, calf soreness, Achilles tendonitis, it might be an issue with your dorsiflexion. So let me show you a good video on how to test your dorsiflexion, see if you have enough. Alright, talus, distal tibia, and distal fibula. Fibula rotates 3 to 5 degrees externally with the ankle dorsiflexion and 3 to 5 degrees internally during plantar flexion. You have a syndesmosis joint, widens by 1 to 2 millimeters during dorsiflexion. So you want that to occur. If you have issues, then you'll have pain with dorsiflexion. Again, going back to that rice, swelling versus inflammation, you want to know that inflammation is good for you. That's the initial response to injury, but swelling is not good for you. That's excess fluid that remains after initial inflammation has taken place. So it relies on the lymphatic system to flush it out, and the only way the lymphatic system works is by exercise, muscle contractions. So our goal is to increase inflammation, but to decrease swelling. Okay, so that's our goal in rehab. I've got subtalar and transverse tarsal joints, which does inversion, eversion. Most ankle sprains are inversion sprains. Say talar, such as also known as the talocalcaneal joint. Transverse tarsal, also known as the talonavicular and calcaneocuboid. Those are classified as gliding or arthrodial joints. And they have a combined movement of 20 degrees of inversion and 5 to 15 degrees of eversion. That's why you don't see too many eversion sprains, but you'll see a lot of inversion sprains. Alright, again, they're arthrodial, minimal movement, especially medial, so that's why you have limited eversion. The metatarsophalangeal joints, phalanges join metatarsals, classified as a condyloid. The great toe, and this is something that's also important to prevent injuries, is great toe metatarsophalangeal MP joint extension flexes 45 degrees, but here's the key. You need it to extend 70 degrees, or that push off. When you push off when you run, you're not going to get that. You have injuries. You'll get calluses here, or you might get funky looking feet. So MP joints of the 4 lesser toes, 40 degrees of flexion, 40 degrees of extension. Again, should I ice or heat? Ice for pain. Icing showed that after 15 minutes of use, it decreased strength, power, and nerve conductivity. So if you don't have pain, then you don't want it to lose strength, power, or nerve conductivity. You can do heat for warming up. And should I use heat before exercise? If you want. It's not, the research isn't really there to say that's going to make that much difference, but do some dynamic stretching, do some dynamic warm-outs. Those would be more beneficial. Great toe interphalangeal or IP flexion flexes from 0 degrees full extension to 90 degrees full flexion. PIP gets 0 degrees of extension to 35 degrees of flexion. Distal interphalangeal or DIP joints flex 60 degrees and extend 30 degrees. Variations exist. Ankle sprains are one of the most common injuries. Sprains involve stretching or tearing or one of the more ligaments, mostly the ATFL. Most common ankle sprains result from excessive inversion that causes damage to lateral ligamented structures, primarily anterior talofibular ligament and the calcaneofibular ligament. These are two good quiz questions right here. Here's the type of ankle sprains. Grade 1 is mild. Grade 2 is usually a partial tear. And grade 3 is a complete tear. Okay. Less common are excessive eversion forces causing injury to the deltoid ligament. So it's very rare to get a deltoid ligament injury, but sometimes baseball players that are sliding into first or second base, they might get an eversion ankle sprain. So joints in the foot and ankle maintain their arches, 2 longitudinal arches. Medial longitudinal arch extends from the calcaneus bone to the talus, navicular, 3 cuneiforms, and distal ends of the 3 medial metatarsals. So you've got that arched foot. And I think, I remember in class I kind of mentioned what kind of foot you have. If you have a swimming pool, coming out of there and then looking at your foot pattern and see what it looks like, you can kind of see if you have a normal arch, a flat foot, or a high arch. Lateral longitudinal arch extends from the calcaneus to the medial to the cuboid and distal ends of the 4th and 5th metatarsals, and long arches may be high, medium, or low. Here's the transverse arch. So these arches, transverse extends across the foot. So some of you have arches, some of you don't. Some of you have flat feet, and you have severe flat feet. Okay, so plantar fascia and the plantar aponeurosis, a broad structure extending from the medial calcaneal tuberosity to the proximal phalanges of the toes, assists in stabilizing the medial longitudinal arch and in propelling the body forward during the latter part of the stance phase. So sometimes if you have issues with your biomechanics, you'll get plantar fasciitis, which is a common painful condition involving the plantar fascia. So if the plantar fascia assists in stabilizing the medial longitudinal arch and then propelling the body forward during the latter part of stance phase. So if you have weakness in the inability to propel forward or inability to move forward in the stance phase, which would be weakness in quads, hamstrings, and glutes, then your plantar fascia is going to get the brunt of it and you get plantar fasciitis. So it goes back to strength weakness. All right, so dorsiflexion, plantar flexion, eversion, and inversion.